I'm Dr. Jian Yi. Welcome to the virtual AP valve and structure heart session of transcatheter mitral valve replacement, device 1. It is my pleasure and honor to moderate this session. So we have a distinguished panelist, Dr. Park, everybody know him, and Dr. Khan, and Dr. Watanabe, and Dr. Yo, and Dr. Chan. So this session, as said, we have one live case and followed by 2 lectures. So without further ado, I will move to the live case at St. Paul Hospital.
Well, good morning, I guess. It's almost evening here in Vancouver. Pleasure to be here. Thank you very much. I'm John Webb. And beside me, I have Alyssa Shook, our nurse, and Janara Sathanathan, one of the interventional cardiologists, Miriam Al-Qadad, who is doing an interventional fellowship with us, and of course, David Wood, the chief of our program. And today we're going to do a transeptal mitral valve and valve. Now, I'm embarrassed because Jan, of course, is one of the first people in the world to do mitral valve and valve. We did these together transeptally for many years, but now most of them are done transeptally, and so that's what we're going to show you. So I'll ask Miriam maybe to introduce the case to us. Miriam, do you want to go ahead?
So good morning, everyone. I'm going to be presenting the case of Mrs. MJ. So she's 74-year-old female with degenerated bioprosthetic mitral valve. She's NYHF4. She's independent for her daily activities. She's also a Jehovah's Witness, which means that she doesn't accept any blood. As a background, she had a previous mitral valve replacement with a 33mm Magna in 2008, and they went through the septum to access the left side. So this is important for the procedure that we're going to do today. She also has AF and severe chronic kidney disease. So she was complaining of progressive shortness of breath for 1 month and admitted for heart failure related to severe MR. So it's a mixed degenerated bioprosthetic valve. There was an initial suspicion of endocarditis, but this was ruled out with no fever and negative hemocultures. So she was treated with antibiotics and referred for mitral valve intervention. So on the echo, we can see that there's a flail leaflet with a severe MR, a high gradient or so with a mean gradient of 19, and she also has a severe TR. Next slide. The coronaries are normal, and we can appreciate also on the angiogram that we can have already idea of the view we're going to use to be coplanar with the mitral valve. Next slide. So the CT scan is very important also to plan the procedure. We assess several things. One of the things that we assess is the neo-Lvo2, which is large here, with a low risk of Lvo2 obstruction using a 29mm THV. We also check that our internal diameter is the same as the one given by the app. So it's 28.5. And we have a look to the septum on our CT to make sure that we don't have any calcification or thickness that could make the transeptal puncture difficult. We also assess on the CT our coplanar view. Next slide. So just a few words about our local experience here in St. Paul. So we performed the first procedure in 2007 with more than 100 of procedures performed since then. And we can see that we clearly changed our practice with 100% of transapical access until 2015. And then we switched for transeptal access, which is now our default strategy. We also have favorable 1-month outcomes with a low mortality and heart failure, and even better in our transeptal cohort with the very good outcomes. Next slide. So here is an example of a case that we've done yesterday. So it was an urgent patient who had a lot of procedure done already. So she had a aortic valve-in-valve that you can see on the left video, and she also had a mitral PVL closure with a plug that you can see on the right video. So In this patient and in all our patients, the transseptal access and the puncture is very important. So we're going to target a mid-superior and posterior puncture of the interarterial septum. And our routine is to use a VersaCross radiofrequency wire, as well as a steerable sheet. So you can see on the video on the left that we just puncture with the radiofrequency wire. We put the energy on, and then we just have to push the wire into the LA. On the right side, so the right video, you can see that we can move the steerable sheet to target the center of the mitral valve, and then we're able to cross using a pigtail, and this simplifies the procedure. Next slide. So the next step is to insert a stiff wire. So we use a Safari extra small wire that we insert in the LV, and then we dilate the septum with a 12 millimeter or 14 millimeter balloon according to the THV size. Next slide. And the other important step is also the positioning of the valve. So here we aim to use a 29 millimeter S3 THV. And you can see this is the same patient so that we've done yesterday. And the positioning here is pretty good. We aim 1 millimeter ventricular flaring at the outflow. Next slide. So to summarize, we discussed the patient in the heart team, and this is a 74-year-old high surgical risk female patient with degenerated bioprosthetic mitral valve, mixed, so severe MR and severe stenosis. We just done the TEE today because she was too decompensated to have it before, and we see that it's really a mixed mechanism. So we plan to pre-dilate also the mitral valve, and then to perform today a mitral valve-in-valve procedure. So
thanks very much, Miriam. So the case that you just showed with the valve-in-valve aortic on the mitral paravalvular leak closure was actually what we had planned for you today, but she suddenly got too sick and had to be intubated. And we did her as sort of an emergency case yesterday. She's doing very well today. It worked out very, very well. So this is our backup case. And we didn't have a TE in advance, but in fact, we seem to be okay. The TE shows the septum, although the surgeon actually crossed it and sewed it up, isn't too thick. And maybe we'll ask Kevin Ong to speak into Janar's mic and just give us a quick tour from the echo.
Hi, everyone. So we have this individual here. I'll just show a couple 3D representative images here. So we have here the 3D on-face view. Here's an under-face view of the mitral prosthesis. At 12 o'clock is the aortic valve. So we can see here we have a flail segment of one of the leaflets. And we can also see that one of the other leaflets is heavily calcified and also very restricted. So we have both mixed stenosis and severe regurgitation. Now here are some color 3D images. We can see here there's a severe jet of mitral regurgitation. Does cause systolic flow reversals in the pulmonary vein, and then of course restriction of flow through the mitral prosthesis itself, and a mean gradient of around 11 that we're measuring right now. There's also concurrent pulmonary hypertension with a pulmonary systolic pressure of at least over 50 millimeters by echo.
Well, that's great. Thank you, Kevin. So I think we'll just get straight ahead. We were a little concerned about the transseptal because of the previous septal surgery. It doesn't look too bad, so we'll hope that goes well. So now we have a 7 French sheath on the femoral vein, and we have 1 ProGlide in there. At the end, we'll put a figure of 8 suture around if we need to, but that'll get us started. We enlarge the hole just a little bit with the scalpel, and we also have a separate arterial and venous sheath in the other leg. Arterial just in case we needed bailout or access to the artery for any reason, although we never seem to. And we also have a transvenous pacer in as well. We prefer that because we could pace on the ventricular wire that we're putting in, but sometimes we have to push or pull on that to position the transcatheter heart valve. So I'm not sure how reliable that would be in this case. So we'll just use a standard RV pacer. So here we go. This is the 14 French, 16 French Edward sheath for the 29 valve. Now, this is a 33 surgical valve, but the ID is just less than 29, so we should be fine. I think Miriam said that we were maybe going to overfill with, or not at all, but I think we actually will overfill a little bit. We'll overfill with 3 cc's, I think, to make sure that's well fixed. And then we always flush the sheath. Oh, I already got, thanks very much, Shnar. And because this can move around when you're not watching it and you're positioning the valve, I always like to put a suture in the sheath. We can always cut it if it gets in the way, if we need to pull the sheath back a little bit during positioning. So we have a 2/0 silk or something, might even be a little bigger than that, on a curve needle. And we'll just sew it down to the skin so it can't pull out while we're not watching it. Jan ties much better sutures than I do. No, he's never. There we are. But it's not too bad, huh, Jan?
You do a great job on it.
It's not pretty, but it works. And then we're going to skip a couple of steps here, and I think we're just going to go ahead with this. This is the radio frequency catheter here. I'm going to put a little bit of an extra curve on it. It usually needs a little extra curve, in my experience. We're not the most experienced in the world with this particular catheter, but it is produced by a Canadian company, which we're very proud of. So we'll just break the sheath with that, and then it comes with its own wire. We're just going to go straight up with that wire, Janar.
Yep.
And it's kind of nice. It usually will just go straight up into the SVC. We'll hope that's the case here. Just go on, keep on pushing it straight up. So there, it didn't do it. There it did. Okay, straight up into the SVC. That's very nice. So now we'll take our transeptal catheter up here. And I'm just going to orient it sort of generally towards the valve. And I'll just pull the wire back to the end of the catheter like this. Now we're going to hook up the back end of, maybe a camera could just take a picture of this. You want to just show the camera, look at the camera and see if they can see that. Hook up the back end of the wire to the radio frequency device. That's it.
Yeah.
And now we'll do our transeptal. So I'm just in the AP. I guess we could angle a little bit, but this is fine for us. We're using ultrasound anyway. So I'm in the SVC, Kevin, and I'm coming down. We have just the long axis. We'll get the bicable up shortly. There, I just fell into the atrium.
That's perfect, Don.
And it's a little high still, do you think, Kevin? Yeah. Unfortunately, Kevin doesn't have a mic. Do you want to turn the lights down so they don't bounce off and on? That's better. They can see better. So it looks to me like we're a little high. I'm just going to come down a little more. And we want to be fairly posterior because we have to come anterior to get through that valve. We don't want to be too low because it's quite a angulated valve. We're going to have a little trouble getting coaxial, I can tell already. Coming down very slowly.
John, in terms of your position, you're based on this previous CT analysis, the way you're.
Well, we've seen the fluoro and we sort of already know, but yes, we did calculate it from CT, and we'll eventually go to that profile view, which is around 40 degrees, I think. Miriam will correct me. Maybe we'll just concentrate on the transeptal right now. We're still a little high, maybe. We're not seeing it real well. I might have to take the catheter out and give it a bit more aggressive bend to indent the septum. I'm going to press and see if I can get some indentation, but no, nothing. So keep on coming down a little bit. We're not seeing nice indentation of the septum yet. I'll try and push and see if it'll catch on something. No. The nice thing about this system is you can sort of go up and down. You don't have to take it out, put the wire up every time necessarily. So we're not really getting nice indentation of the septum. I put a bit of a curve on it, but maybe a bit more. This may have something to do with the previous septal surgery. Most of the surgeons go, what is it, a interatrial, so in the AV groove. But some surgeons actually go from the right atrium. And Jan, of course, knows a lot more about that than me. I think most surgeons use the interatrial groove these days. Okay, so I'm not getting a good indentation. So I think what I'm going to do is put the wire back up, the SVC, take the catheter out, and I'm going to put a tighter curve on that. So we indent the septum. Just take it right off the wire, I think. and hand it back up to me. Okay, so let's get a little more aggressive with that.
Do you think this is because the previous surgery has more scar, the thickening, and need more push to get
Well,
it?
I wouldn't be surprised because it's okay. We'll put that on the wire. I wouldn't be surprised. I don't want to blame the surgeon, Jan, but maybe. But we'll try this. We'll fix it.
This might have been why it was the backup case, Jen.
That's right. You selected the challenger one.
Well, the other one was really interesting, but unfortunately, she just got too sick and had to be intubated and done more urgently. Okay, so we'll go right up here. It's see, it's fairly easy to do with this system. We'll take the wire out now. Sorry, back, I mean. Oh, I guess I can do that myself. There we are. Just inside. Now this wire is going to be energized when we get in the right position. We'll perforate the septum with that. So I'll just get it inside. And Kevin, I'm coming down from the SVC again. I'm hoping for more indentation this time. Oh, I just fell into the atrium. And yeah. I'm going to push and see if I can indent something. I'm really not getting good indentation on the septum. You have to do this right, or you're going to defeat the whole procedure unless you get a nice transeptal puncture. See if I can get indentation somewhere. So I'm pressing fairly hard, but we still don't see a nice indent on the septum. Is that it fairly high up there, maybe? Yeah, I think so, but it's far too high, I think. Coming down again.
I think the other two, hi John, morning. I think the other two catheters in there really makes visualization a pain.
I'm not making any contact. Okay, so listen, we're going to take this out, get even more aggressive. You want to take that out, keep the wire up there? Yeah. Okay, eye wire.
So has anyone on the panel had any experience with the ViscRoss system?
Oh.
We'll stick that on. Well, the case yesterday, the transeptal puncture took about 60 seconds.
Oh.
So always the way, isn't it?
I think it is because the surgeon did the surgery. That's why.
Yeah, definitely.
Yeah.
Some different anatomy. Yeah.
Okay, so let's go up again. We'll start. Always a good idea to get up to the SVC and start up there to standardize this. And okay. So Kevin, I'm coming down again. I'll just get that side.
You can see our catheter there now, I think, Kevin.
Should be. It might be a little low, but here.
Just bring
I've been trying to indent here fairly aggressively.
L.
Not really, huh? Let's go back up again.
Because we have an M.
Coming back down again, Kim?
You know, we could switch to a standard transeptal needle system, but I don't think that's really going to do any better than this. It's just an unusual HM.
Regular one is stiff than this system.
A little stiffer, yeah.
And then you can push even harder.
You want to get a BRK1 system ready to go. Transeptal sheath. Just open it up. Is that me you're seeing on the short axis there in the middle of the septum?
And we need a
Kevin?
SO1 sheath as well.
Is that me in the middle of the septum you're seeing on the short axis, do you think?
I think that's the pacemaker wire.
Yeah, I think so.
I think that you can use the aortic valve on fluoro as a little bit of a guide as to where the needle is in relation to the septum. So you know how sometimes when you're very anterior, you get into the space with the aortic valve. And so I think you're getting close there. I think that's on the right-hand image there. That may be the transeptal needle. There you go.
Yeah, that's what I was thinking as well. But I'm not getting any. Part of it is I can't get an indent because the septum's a little thick. I think being post-surgical. Let's see if we can. No, really not getting an indent at all.
And another thing, I'm not sure that this patient, this surgeon was used a prolonged suture or the regular like absorbable suture. That may also make a difference.
Yeah.
Because the prolonged suture is probably more like a stiff with a permanent.
Yeah. Yes. Okay. I'm just going to go way more posterior and see if that helps at all. No. Okay, let's, do you have the standard transeptal catheter
We
there?
do. We have an SO1 sheath and
okay, let's give it a try.
Okay.
You got it there?
Yep.
We get this pigtail off the field. We're not using it. Okay. Transeptal catheter and needle. Need the wire first.
so where's the SO1 sheath?
Not that wire. The O28 wire for 32.
So?
Okay, let's put it
You wanna
inside
put the
here.
wire here? And
Put it in.
so let's get rid of this. What's this?
Put the wire right out the end. Just keep on going. So we switched to the regular system. I've never had to do this before, but okay, let me have a feel of that. Okay.
Can we flush this?
Let's go down and find this. Okay.
Yeah, I'll do that.
Is this wire damaged here? It's not going out the catheter. Hold on a sec.
Do we have another wire? That
Just
comes
use this one if you need to. Here.
have this one.
We'll try this wire. It's not going through the. Did somebody put the needle inside this catheter? It's got a burr inside it. I need a new transeptal catheter.
Can we open another BRK one?
Not a BRK one.
Sorry.
Transeptal catheter.
SO1 sheath, please.
I just out of curiosity, had the needle been put in that catheter? No? No, okay. Because the wire wouldn't pass through the catheter. Sometimes it gets a burr in.
So let's take that one off the table, yeah, Gerard? We know it doesn't go.
So we're just waiting for a transeptal catheter. We have the wire up the SVC nicely. Sometimes that's a little bit of a rub.
John, is most centers consider this as a sort of a relative contraindication transeptal approach after surgery?
I'm not sure most people even consider this as an issue because probably most cardiologists aren't that familiar with the fact that people, you know, the difference. And so it's part of our routine is actually usually to do a TE or if not a CT to look at the intratracheal septum. But this septum doesn't look all that thick. I mean, I'm not trying to tell you it looks terrible, but it must be thicker and more fibrosed than usual because we are having trouble with it. So here we are in the SVC. We'll take the needle.
And John, what kind of a Agilis did you want, or you wanted to?
Medium.
Medium. Can we
Okay,
open a medium
so
Agilis, please?
Here we go. We'll put this up. There's a stylet in it at the moment. We'll leave it that way for a moment. I'm going to take the needle out now. Oh, there's no needle. There's no stylet in there.
There's
no,
a stylet there.
Oh, it is
still.
there. Yeah. Okay, there we are. And get a manifold for this. Give me the angiographic manifold. Thanks. And a syringe to flush it, please.
Yeah.
It's this here.
Okay, I have a standard transeptal catheter up here, and there we are. Okay, so I'm coming down, and maybe we'll add a little bit of LAO to make us a little more perpendicular to the septum. That might help a little bit. And so I'm coming down, Kevin. SVC still. Fell into the atrium. Coming down, running into the pacemaker. We can always fix that later. So I'm pressing on something. I don't see any tenting of the septum whatsoever. So that, you know, we're making this look difficult today, unfortunately, but this is becoming an increasingly common procedure.
Definitely.
I would think that we're doing, you know, one every couple of weeks now. And it really has rapidly become the default for rather than redo. I'm not seeing my needle there at all on the echo, Kevin. Is that my needle there, maybe? Uh-huh. It looks like... Uh-huh. Okay, give me the wire again. The difference is with this, I find usually you have to put the wire back in, unlike the VersaCross radio frequency system. And sometimes the curve on the catheter makes it a little bit difficult to get it to go straight up. But there we are. That's good. Okay, try it again. Take that. Take the needle back.
Yeah, got that.
Thanks. There's no stylet in this time. And there we are. Okay. Okay, well, I'm coming down. Okay, I just fell. It looks like I'm still way too high. it's hard to believe I'm in the IVC. Yeah. I don't see any tenting of the septum whatsoever. And you're not seeing me against the septum at all. Okay. Yeah. So we're going to have a look at the 3D. And we'll see if Kevin can find us on 3D to see what's going on. Okay, so give me the wire back. We're going to put a very aggressive bend on this.
Yeah.
And it's already got an aggressive bend, but more. We guess we just have to get more aggressive. What can I say?
Absolutely. This is not each case, and the prior surgery, and
yeah,
this is the one of difficult case.
This is what happens when you get backup cases. Okay, so I'm going to put a bit more of a bend on this. So I don't know if you can see that at all. There. Sometimes you put an aggressive bend on that, you have trouble getting through the transeptal sheath, but that one actually went very smoothly, so we seem okay. Okay, here we are. So coming down again. Okay, I'm way too high, I think.
It's the wire.
We put the echo up, please.
It's this one as well. Yeah. Yeah, let's just keep this together.
Do you want to point to me what you think the transeptal catheter is? That right there? Yeah, okay. So oh, this is a very difficult one.
Any comments from Dr. Park or any panelists? Any comments or this?
Anybody have any suggestions? I'm certainly open.
Yeah,
to them.
yeah. So, and this is I think one of the typical cases. So, and I have many experience of the percutaneous mitral valvuloplasty. It's such like LA size is big and pulmonary hypertension is severe. Sometimes septal function is so difficult. At the time, so I think one resolution is to make a very sharp curve. That is the only one solution, and make some
a very sharp bend at the tip.
Yeah.
Yeah, this is.
How it is seen.
So I'm pressing on something. You don't see any tenting there at all, do you? Who knows what I'm pressing on? You know, you have to be willing to go a little ways in this situation, but we can't exit the needle until we see indentation of the septum. So we're still relatively safe here.
Is there any interaction between the pacemaker lead?
I don't think there's any real. I mean, yes, obviously they are touching, but I don't think it's interfering with this. So I could pull it out, but I have to put it back in again, and I don't think we're causing any trouble.
I'm just wondering whether the pacemaker wire is just making imaging a pain.
Okay, that's a good point. So we'll pull the pacemaker wire back,
Okay.
and we'll see if it makes any difference.
Okay, good.
That's valid.
Mm.
We can put it in quickly. We even need to. We can paste on the wire. I doubt it's going to make a difference, but it is a good thought. And normally, I don't go back and forth in the HM like this. The wire.
Pacemaker's removed, Kevin. Now you just have that IJ line, and that's it.
Yeah.
And the Dr. KKO and the Dr. Gang, you have many experience on mitral valve tear, the procedure, and I think that is sometimes happen. It's like septal approach is so difficult. How can you resolve this situation?
Syringe?
KKO or Dr. Gang, any comment for that?
Yeah, I have had one such case like this, which I really struggled, and we had to make a big curve. But in the end, the big curve did cause complications. I was looking at the imaging on the X plane, and I think there are times where it looks like we can see it on the X plane. I wonder whether, as John comes down, whether we could shift the view to X plane instead the other way around. It might be able to get a sense of where this needle is. But this is a really difficult case.
I put the wire up there. Actually, I've got it. Okay, and I'll take the needle first quickly, and I'm gonna put an unusual bend on the very end of this thing, and we'll just have to be careful with this. But we need to do something a little differently, a little bit more aggressive.
You can see John's put a very aggressive bend on the curve there, as suggested by the panel.
Yeah, the other thing I thought that I heard was the mention of the agilis. That might be also another option.
Well, I think that's a good point. I see. Let me get the needle up there.
Okay.
And we'll see. Maybe it's just way more posterior than we thought. Yeah, I'm coming down very posteriorly. Just fell. So I really have this over tort to make it very posterior, but it isn't really helping. I think we'll try a little more lateral and see if we can at least get into view. Still no indentation whatsoever. Okay, let's, do we have a Agilis?
We do.
Yeah, let's just open up the Agilis.
Yeah, Agilis is ready to go.
Okay, so take that out. We're going to give it flush.
This is a medium, Janard?
Yeah, thanks.
This is a Agilis medium, yeah.
Okay, and you have a
1 second.
Wire?
Yeah.
Well, this is good. We're doing a master class on transeptal puncture, Jan.
Oh, yeah, that for sure. This is a most difficult one.
Yeah.
It's small. The air.
Yeah.
Yeah, we'll just try this.
Yeah, I think this the live demo is very educational, and for the many interventional cardiologists, definitely meet a similar case.
Okay, so let's get the needle, transeptal needle.
And I think the logical step-by-step approach is really
with the with the line on the back. Just put it on the back.
This is a more educational.
Flush it through.
Definitely, sure.
Flush it through. Okay, that's good. Okay, well, so we're up there with the needle. Hopefully this needle is the right length for this Agilis. And it is not. Okay, I guess we need a longer needle for this, don't we? Okay. Okay, I think what we'll do is we'll take the VersaCross system again, and we'll
that's
use the
flushed?
VersaCross.
Yeah.
I did flush.
We'll get the VersaCross all ready to go,
And do you have the VersaCross wire there?
and we'll use the flexion aggressively on that.
It's the one that looks like a bit of a.
So we're going to need the wire ready to go, the VersaCross catheter. Just bring it straight up.
That there, yeah.
I wonder if the echo is seeing the end of the catheter that's in the
So we need to introduce
superior vena cava.
Oh, yes, absolutely.
It is, Rob. Yeah.
And I wonder if you can use that as a bit of a landmark.
So Kevin can't hear what you're saying. So Kevin, Rob is wondering if you're seeing if you can use the catheter in the superior vena cava as a landmark. There's a PICC line or something in the SVC, and he's wondering if you can use that as a landmark. Can you just advance the wire?
Yeah.
Okay. Okay. We'll just pull this back. And now we can't flex it that much because, of course, there's the dilator in there, but we can somewhat. I think we'll just try this and see if we can. Good thing our VersaCross if we can bail ourselves out with it.
So he's just coming down.
I'm in the SVC, Rob. I'll give you a second.
You're going to try a bit of flex on the VersaCross.
I've done it already. Yeah. And
it's near.
Oh, there you go.
Good, good, much better. Wow.
Is that good enough? Can you check other views?
So we're ready.
Are we ready with the VersaCross?
And who's on the back table there, ready for the burn if we need to? Thank you, Blair.
Tell me when you're ready. Are you happy, Kevin?
Yeah, you're a little bit posterior, but
How about we just go with this? Okay, ready with the RF?
Oh, you might be through.
Yeah.
Oh, am I through?
Yeah.
Okay, without turning the RF on, unless you hit them. Okay, well that's even better, huh?
Yeah, good.
God, that the RF just works so well. Okay, so now we're going to hold the dilator there. We're going to
good.
advance this across.
Wonderful.
We're going to take that out.
Good.
Go to the implant view, please. Implant view.
Let's take this all out, please. Yeah.
That's so interesting, eh?
We're going to
the
bleed
medium
this back.
agilis, the VersaCross didn't require power.
You can give
that was with me actually flexing the VersaCross, right?
You have the
So not just bending the catheter. So now we want the pigtail. Yeah, we could give heparin now.
You saw John's hands there, how he was torquing that, eh? Wow.
I think this case is very educational case. Yeah.
Pigtail.
We're heparinizing.
So,
yep.
Wire at the end. So we're going to aim at the valve and cross with this. Now you could use just a pigtail, maybe get across, but this usually works very, very well.
Small, please.
Yeah.
And so we'll find the implant view. We'll rotate this. We'll point it right at the valve.
So we have
usually go to the surgeon's view on the echo.
It's there.
But I think we're sort of okay here. It should just go, hopefully.
What size?
And there it is.
Good. Great.
Okay, now I need the
wire out.
You're going to see a
heparin's gone in, right, Kevin?
mitral valve implantation in 10 minutes, hopefully.
And next will be the balloon.
That ectopies us, the wire.
Okay.
Let's take this off the table.
So now the Safari Extra Small. I like this. It fits very nicely in the apex. And there we are. Okay, we have a wire in the apex. Can you take that out?
That's live fluoro, John?
Live fluoro.
And once that's settled, we'll reposition our pacer.
Let's take this out. Just let me know when you have wire, John.
Okay, keep going. I've got that.
You have one.
Okay, we're going to reposition thanks for reminding me. We're going to reposition the pacemaker now before we take this out. AP, please. AP.
Here we can push this, please.
Somebody move the table for me.
Yep.
Actually, it's not too bad. Thanks, Janar.
So let's load the balloon on.
This is the 14 Armada, right?
Correct.
Yeah.
And you've taken the cover off of
Yeah.
it.
Okay, let's more easily said than done, huh? There we are. Okay, that's maybe, if we let the balloon down, it might settle into a good position. Could you test the pacer there for us? Output of 1, rate of 100.
I don't think 20 is enough for the balloon, no? 20 cc is not enough. I think.
Sorry, that's our Safari wire.
Is it capturing at 100, do you think? Yeah, okay, we're going to come back a little bit. Oh, that's better.
That's better.
How about that?
Yeah.
Okay, I think that's good enough. Pacer off. Okay. Oh, is it still VT? Okay. Coming back a little bit. You want to try again? All right, still VT, you think?
I'm just gonna. Okay.
Okay, so we're going to go ahead with this, and we will open up the system for pacing on the wire. Okay. What's this? This
Okay,
is
so the alligator
okay.
clip.
Did that go to the 7?
It will. Yeah. Okay. So we're going to dilate the intraatrial septum and worry about the pacer later.
Mm-hmm.
I'm going to pull the pacer back. Are you pacing or is that the VT? That's her. Okay, I'm pulling the pacer back a little bit.
Do you
If we need to take,
on the screen at the same time?
yeah.
Sorry, John. Just hold on.
Guys down in the control room, Anthony, can you?
Can we go to the implant angle, please?
They want to see the pace. They want to see the rhythm, I guess, huh?
Yep, they have all three, John.
There we go.
Okay.
You have the fluoro, your hands, the rhythm.
Okay, we're going to dilate the intraatrial septum. We're using a little bigger balloon than usual, a 14 than normal, because of concerns about the surgical status. Okay, start going up with the balloon.
Don, are you able to put the echo up as well or no?
We're just going to look at, yeah, there we go. Okay, keep on going. There we go.
Okay, okay.
Go
What
all the way.
size? Okay, what size is balloon? 14?
It's a 14. That's a little
14.
big.
Okay.
Sometimes there's an AST that we have to close, but I'm concerned about the thickness of the septum. If you have trouble crossing, it's very difficult to solve that once you have the valve in. So I think that's a pretty good dilatation.
You want to do it again, John? Or?
I think we'll just call it quits. Let's take it down.
Yeah.
Okay.
Just need to check the orientation, John.
Blair, can you give it?
Looks like a surgery doesn't cause any bigger problem. It's easy to dilate.
Yeah, we're just, okay. So do you want to take that balloon out?
Yeah, I'm taking a slide fluoro there, John.
Yeah. Keep the wire out there. While you're doing that, I'm going to, can you, just hold on a sec.
Can you just go up top and fluoro?
Can you just show John on the back table here? Can we just show John?
Seal in the LV, in the LA, open cells in the LV, flow from LA to LV. You need to check that yourself, I think. Let me go up top there, Miriam. You don't want to put a valve in backwards.
This is live fluoro, right?
You're still coming back. You keep on coming.
Good, good.
So John, just check that just to make sure.
Just let me know when you have wire, John.
Great, thanks.
I have wire. Okay, take that away. It's snagged there. Do you want to fix that, Miriam? There. Okay, good. Thank you.
You've got wire, right?
Yeah. I have wire.
Do you think we can go on the screen at the same time?
Yeah, so if we'll take down the hemodynamics and put up echo, please, Don. I don't think we can have 4.
Dave, do you mind just telling them what to put up like you're doing? That's great. I don't want to look at that.
There you go. That's perfect, Don. And just leave it like that.
Try and get the case.
We'll report on the hemodynamics, but I think this will be more interesting for the panel.
Okay, good.
You have wire, John?
Yeah, I have wire. Okay.
And we got the cables to pace off the wire, right, team?
Yep, they're there.
So we're going to pace off the LV wire. We never do that for this procedure because we sometimes have to move the wire, but in this case, I think we will. So we need to bring the valve up here. We're going to put a little needle in the skin, and that will be one pull for the pacer.
So 29 millimeters plus 3.
To compress this.
Okay,
there we are. Okay,
and
good. It's on there well.
Did we do an ACT? Thanks so much.
Okay, bring the valve up here, please.
So 29 millimeters plus 3, John. You got it, Miriam?
Okay.
Yeah, Miriam, back.
Yeah.
There we go.
Good.
That's good. Okay.
Yep.
I'll put that on the wire if you can.
Okay, good.
That's perfect, Don. So just those 3 images for the
Okay, John, can you briefly, shortly explain which valve is now used?
People only use balloon expandable valves, and 99.9% of the time that means the Sapien 3 valve.
Sapien 3 valve. Okay.
So we're going to have a look again. Seal in the LA, open cells in the LV, flow from LA to LV. Don't want to put it in backwards. Okay.
So that's the final pause.
So we always fluoro make sure that the wire hasn't pulled out. In all that excitement, it has pulled back a bit, but it looks like we're okay.
Yeah. Okay, great.
I mean, yeah, you want to check that before you put the valve in. Can you bring it up there again?
Yeah, just hold the wire there.
So I have to add 3C.
Don't hold the system.
Yeah.
Don't hold it.
Yeah. Fluoro there for a second, John. Sorry. Do you mind
just come on? What? Oh.
Yeah.
Yeah. Just come close to me. That's all. You're not doing anything inside the patient.
Yeah. There you go.
Good. Okay, good. Okay. So don't hold the wire, please, unless I ask you to. Thanks. Okay.
And we're upside down on the system here.
What?
Oh, just E down.
Oh, okay. Okay, so we're in the sheath. No tension on the wire yet, please.
I'm not holding anything.
I want the wire pushed ahead, if anything.
Okay.
Okay, and I'm through the expandable part of the sheath, getting into the expandable part of the sheath. We'd like to get this out when we do our alignment, but we can't really. So I'm going to get started with the alignment inside the, advance the wire?
Yeah, I am.
Inside the sheath a little bit. And then we'll push this out further.
Good.
And we'll bring it back further to the mid part. Good. And then we'll advance it out completely out of the sheath.
Mm.
And now we'll align it with the balloon. So we're going to go to that distal marker there. Good. Okay.
Do you want to test the pacer at this point, John?
Yeah, this is a good time to test the pacer. Can you guys take care of that?
Okay, so we're hooked up. Do you want to test the pacer?
Yeah, so we're going to test the pacer. So we're going to test at 100, output of 20, sensitivity of 3, and backup heart rate of 40. So we're going to test with the tester part. So pacer ready? Pacer on. Okay, it's capturing.
Put the rate up to 120, please. Okay, that's right. Good. You can stop pacing.
Okay.
And we're going to pace at 180 when the time comes, Blair.
With the output all the way up.
Yeah.
We're pacing off the wire.
So
you can see.
We're across here. So now I'm going to orient this sort of the wrong way for a aortic case and start giving a little bit of flexion.
Mm. Good, good.
Not too much. And then I'm going to advance this, and it's going to get up. It should cross the valve fairly easily. There.
Good, good.
And John's holding his own wire.
We're going to unlock this and bring the flex cap back. And you always need to take that flexion off at this point. That'll make the valve flatter. And we're going to pull the flex cap back even further. You don't want the Sapien valve to go into the LV. It might get stuck on the wrong side of this valve. So I'm going to try and torque this a little bit. And it's very hard, isn't it, to get it coaxial because of the angle this is, but we'll see what we can do. I'm going to turn the steroidal catheter the wrong way.
You can see John's hands there in the corner.
I think we're going to have to push on the wire in the ventricle to push this out and then force it, and that's helping a bit. I think we're going to have to go very, very slowly, guys. I don't think I can do too much better than this. We usually can do much better in aligning it.
Do you think a push the guide wire will be a...
That's what I've been doing. I'm pushing some more. And I'm going to push it back out a little. Okay, ready with the pacer?
Yeah, John, we're not locked here.
Lock it.
Yeah.
Pacer on. Start going up.
Going up slowly.
Yeah. All the way. All the way.
That's
Okay.
1,000, 2 1,000, 3 1,000, and down.
Pacer off.
Great, great.
Advance the wire for me. Advance the wire
So
for
that's
me.
a 29 plus.
Okay, that's pretty good. Pull the wire back inside the flex cap. Just pull it back. Pull the wire back. Good. Okay, good.
Good.
Very nice.
Good.
Can we put the hemodynamics instead of John's hands?
Okay.
Just to show the.
Sorry. I'm
dramatic
exhausted.
change, please?
I think we're going to take the flex
Look at
cath
that.
out. I don't think we want to do anything more to it. So I want you to I want you to leave the wire in the left atrium while we look at the ASD.
Yep.
Very nice.
Can you make
Nice positioning though, huh?
Can you
Perfect
make
positioning, I
echo
think.
large, please, and put the fluoro small where
So
the
I'm
echo
glad you
was?
saw that.
Thanks.
Good. Okay.
Yeah.
We're out.
And then fluoro small. Thanks, Don.
Put the wire.
Okay.
Well, better,
Okay, great.
better lucky than good, huh?
Yeah,
What's that?
Yeah.
29 plus 3, Jen. 29 plus 3.
Nice.
Good. Excellent.
So the valve took 10 minutes, the transeptal 50.
Oh, we knew we had an hour.
You can see the hemodynamics there as well.
Okay, John. And during the looking at this procedure and the people implantation, the make sure some alignment is looks like very difficult. And during the slow implantation, you make sure some axis and alignment. Could you more comment on that?
Could we replay the deployment, please?
We'll make the.
So I have to say, this was unusually difficult. Usually the valve is more vertical than this.
Go back one on
So
the floor.
usually we can get very coaxial.
Back.
The tricks are, don't use the flex in the catheter
here.
to flex
Okay,
because
here.
all it does, see,
At this moment.
in fact, you would prefer to be able to push the catheter up on the left, see, and that gets it more horizontal. So we always take the flexion out.
Okay.
We take the pusher catheter right back. If anything, we flex the wrong way to the right of this, to the left of the screen. The other thing you can do to make it more horizontal is go too far with the stent and then push on the wire, and that'll force you back. See, I'm pushing on the wire, and that makes me a little more horizontal. But also remember, we play that, please. Once it starts to inflate, it'll pivot around the point of first contact.
Wow.
And so that's really
That's
what
nice.
saves you, is figuring out where it's going to pivot. And there it was a stenotic valve, so it pivots on the outflow, and then it straightens itself out.
Okay, great.
But this is perfect position. You know, you have to anchor on the surgical valve ring.
Echo picture.
And you have to get the sapien to the tips of the valve post so it holds the leaflets open. It has to be a little bit bigger in the LV than the LA because that's the force of the LV contraction will tend to push it into the LA. So we dilated this to over 29 and the valve ID is 28.5. I think it's quite secure. The hemodynamics are probably excellent. Do you want to just let Kevin speak into the, we'll just get our echocardiographer Kevin Ong to comment into
Get nice and
the
close.
mic here.
So we have the valve well seated here. You can see on the 3D images. Do you have the images up?
Okay, we can see.
And you can see all 3 leaflets opening nice and well from the bottom side, from the top side. We're going to put some color on. You can see here, there's just trivial amount of intravalvular prosthesis regurgitation. So overall, very nice result.
And John, you finished with,
there's no evidence of any Lvo2 obstruction.
you finished with 15 seconds to spare, John. Very nice.
Excellent. Wonderful case. Wow.
So thank you very much for joining us. And we're sorry to take so much time with the in fact, we never truly did a transeptal puncture, did we? No. we actually pushed so hard on the catheter that it went across without the needle or rate of frequency. But thank you very much.
Thank you so much. And one last question. When you half deployed it, did you push the guide wire up a little bit? Seems like it's going up.
I was actively pushing on the guide wire. So I'm pushing on the apex, and that would tend to cause the valve to become a little more coaxial.
Excellent.
So yes. But I have to say that was an anxiety-provoking deployment, wasn't it? Because of the angulation.
Yeah, definitely.
They're usually not this bad. And,
appreciate John. This is definitely the terrific cases. We learn a lot of things about everything about the TMVR. This is a really great case. Wonderful.
Well, thank you very much for joining us, and thank you to everybody here in the room in Vancouver. Have a good day.
Thank you. Appreciate. Thank you.
Thanks. Bye-bye.
Okay, so I think we're going to move to the lecture. Go on to the lecture. The first lecture by Dr. Blanky. So I don't think I need to introduce him. He's a radiologist, well known everywhere in the world. He's been the charge core lab for all the clinical trials for CT analysis. So he will giving talk on CT for TMVR planning, imaging specialist tips and tricks.
Thanks, Jan, for the introduction. I'm blushing. I don't know whether you can see that on the camera. I think the talk is a little bit more general. We were just in a valve and valve session. I have some slides on valve and valve, some more general slides, but I'm just trying to keep it practical. In terms of CT, and we have seen that just in the case before, CT is what we in Vancouver sometimes do make the distinction to echocardiography, referred to as the anatomical truth machine. CT is important for sizing, for prediction of anatomical risk. In case of mitral interventions, it's mainly Lvo2 obstruction, for access planning, and then for fluoroscopic views. So let me first focus on sizing, but before I go into that, it's, I think, important to realize that all those concepts, they apply whether you're doing a special, like dedicated mitral implant, such as nowadays Tendyne, or investigational devices as the Intrepid system or the 3M system. Those concepts, they also apply if you do valve and MAC, valve and valve and valve and valve procedures, valve and ring procedures. So sizing, I think, is the most important topic in native scenarios. We mainly perform nowadays 3D contouring, 3D segmentations that automatically yields area perimeter. For some devices, also intercostal or intercommissural or septolateral dimensions. It really depends on the kind of device you're using. It's specific to the device, what the manufacturer is actually focusing on. Sizing is not everything. It's, I think, also a strength to really understand the pathology and anatomy. On the left-hand side, I have an example of an FMR case. On the right-hand side, DM are totally different anatomies of the landing zone. And of course, echo is the main modality of choice to actually investigate the pathomechanism. But I think CT can really contribute in the amount of information. For example, in DMR here, we have a case with massive prolapse. There is mitral hernia disjunction. And if we just consider devices which actually anchor with the leaflet apparatus, they will have a hard time in those scenarios. The other strength, of course, of CT is calcification. And I think everybody who reads those scans and conveys the information to the interventionist should have a somewhat grading scale, a standardized grading scale. We use a 4-tier system. And this is actually independent whether we actually read scans where calcification is an obstacle, for example, for Tendyne or for the 3M system, versus where calcification is needed for anchoring. For example, if you implant a Sapien 3 into the mitral apparatus. In terms of measuring calcified structures, I think it's important to not only stick to standard MPR views, which are typically thin sliced, but to actually employ what we refer to as maximum intensity projections, which give you a more three-dimensional picture and actually allow to perform a contouring and like an understanding where the device is actually going to anchor in patients with severe mitral hernia calcium. The other topic, as I already mentioned in the introduction, is Lvo2 obstruction, which of course is an adverse event in any mitral valve transcatheter procedure. So in terms of the mechanism, what happens if you, for example, implant a Tendyne device, the anterior leaflet is displaced towards the septum, and the native Lvo2 is extended into the ventricle, which we refer to as neo-Lvo2. And that's, I think, an important concept to understand. Whatever you're doing, you actually really, you're not touching the native Lvo2, you're just extending the Lvo2 into the ventricle. And our task is to somewhat assess prior to the intervention how large this compartment is going to be. And the planning really depends on what kind of intervention is being performed. In valve and valve settings, as we have just seen in the live case, what happens is that the bioprosthetic leaflet of the surgical mitral valve is displaced towards the septum. The transcatheter valve forms a membrane-covered cylinder. And for that reason, we just simulate this procedure by overlaying a cylinder. And it's important to understand how far those leaflets reach. In valve and ring, it's a little bit more difficult because we don't have this anatomical guidance what the posts provide in a valve and valve scenario. So what we typically do is we simulate just a cylinder with the same diameter as of what is being implanted. And we typically go all the way up to the post. First, we perform an annular segmentation, just that the system knows, the computer system knows where to actually place the cylinder. The next step is then to perform a centerline segmentation to actually end up with a cross-sectional area, and typically we focus on area and not on any millimeter dimensions. So the question is always, how do we actually place those cylinders? As I already mentioned, we typically go to the top of the tips. And here in a case of a magna, it's actually easy to understand. You can see on this macroscopic specimen, the leaflets, they go almost all the way up to the post. However, there's often some discussion in our like interdisciplinary meetings. Surgeons, they tend to say, well, you know, the leaflets don't go all the way up to the post, especially in porcine valves, as shown here for the EPIC. However, it's important to understand that we actually do not see most of this material covering the post on CT. In the EPIC situation, we only see hypodense posts. And what we actually see is a polymer which is underneath the fabric. So in reality, those leaflets actually go all the way up to the post as we visualize those on CT. And then the same, for example, for the mosaic valve, we see those radiopaque markers. Of course, there's tons of fabric on top of the polymer. You can actually see the markers here, and it's easy to understand that while the leaflets don't reach the level of the fabric, they reach the level of the radiopaque marker. So when we perform the simulations again, we look for those markers and we place those cylinders all the way to the top of those markers to perform the simulation. In terms of cutoff values, there is exciting work out of Cedars-Sinai. They pulled tons of data sets. They defined the cutoff as 1.7 centimeters squared. It's, I think, very conceivable. That's also when we see increased gradients in aortic stenosis. The question, of course, is 1.7 centimeters squared the same independent of body mass and body surface, or does it have to be indexed? And is there any influence of the shape? For example, a more like globular LVOT may be more efficient than a more crescent-shaped neo-LVOT. And I think that's up to the engineers to decide with more advanced fluid dynamics to have a more granular assessment perhaps in the future. Now, of course, the question is when to measure in the cardiac cycle. In the beginning, we always would measure at end systole. There is some evidence that you may want to also consider mid-systole. Of course, if you use the same cutoff values, you will have a lower screen-out rate. That's, of course, not surprising. I think it's more important than just focusing on a cutoff value. It's, I think, more understanding what happens throughout the cardiac cycle. Are we looking at patients where the neo-LVT starts off small at end diastole and stays small or becomes a little bit smaller? Or are we looking at scenarios where we have a large neo-LVT at end diastole and a small neo-LVT at end systole, which is perhaps more beneficial because when there's most flow at peak systole, we still end up with a very large LVOT area, or rather large LVOT area. My last slide is focusing at what John was struggling with, is the assessment of the fossa ovalis and interatrial septum. That's actually something which cardiac imagers, CT imagers, are not that familiar with, and sometimes there's a little bit of difficulties with understanding the directions, the importance. What we typically do is we measure the fossa ovalis height. We also perform an assessment of how thick the septum is. Here, a case of lipotomous hypertrophy. You can nicely see the fossa ovalis here. Of course, John mentioned earlier, sometimes we have scenarios where patients had transseptal surgery, and in those cases, we actually focus on detecting calcifications, and we particularly point this out in interdisciplinary rounds to avoid cases where it may be not possible to actually cross the septum. Thank you very much for your attention.
Excellent, excellent overview and CT assessment for the transcatheter mitral valve replacement. So we are going to have a discussion after the second lecture. So we are move on to second lecture first. And next lecture will by Dr. Bone, Rob Bone. He's an interventional cardiologist, and he's a primary operator for transcatheter edge-to-edge repair, and he is involved many this kind of clinical trial, and he's also the PI for the multiple center trial at the St. Paul Hospital. So, and also involved all the transcatheter mitral valve replacement. So he's excellent interventional cardiologist. So he will give a talk on transcatheter edge-to-edge repair versus TMVR. When should it be considered?
Thanks, Shannon. Thanks, everybody, for inviting me. This topic could take like a full hour, but I'll try to do it in what I have is 8 minutes. So I may skip through some slides, but I thought I would put up the key slide right at the very beginning. And so I think we wrote this paper about transcatheter mitral valve replacement. It was published in March, but the main takeaway points are that there is emerging data to support the use of transcatheter therapy for MR. TEER, or transcatheter edge-to-edge repair, is the first choice, but anatomically there are many patients that are not suitable. And in those patients, TMVR might be the best option. TMVR is better at reducing MR, but it's critical that the imaging piece is well thought out before you choose the device, and you need excellent imaging to do the procedure. As we said, TEER is the first option, and so TMVR should only be considered in patients that are suboptimal for repair. In terms of the systems, you want a system that's safe, simple to deliver. There's low risk of Lvo2 obstruction. It's fully repositionable and recapturable, and it has acceptable durability and repeatability. And then just the big reminder that surgical intervention is really the procedure of choice for operative candidates with degenerative MR, and also for patients with functional MR who have targets for revascularization. And the final piece is that anticoagulation is required in patients with TMVR, but which therapy, the dose, and the targets is really unclear. So when we think about TEER versus TMVR, what we're really saying is what is going to give the best option for the patient? How are we going to create the best success? And success from a patient point of view is their improvement of their symptoms, their quality of life improves, they prevent progression of LV dysfunction and reduces the patient's mortality. From a procedural point of view, you want low morbidity and low mortality and get a successful implant. And these are sort of factors that influence the clinical success of a procedure, but from a procedural point of view, it's really all about the anatomy. I just highlight the 2020 guidelines. They're very complicated, but what I really want to show is that transcatheter edge-to-edge repair is now in the guidelines for both degenerative and functional. And the key component of all of this is that the anatomy needs to be considered. So this is a publication that's old from 2018, but I think is still relevant. And so we, in general, in our transcatheter rounds, we grade patients in terms of their anatomy in green, yellow, or red. And what we're talking about is their suitability for transcatheter edge-to-edge repair. And so central A2, P2 with no calcium, a big valve, long posterior leaflet, flail gap that's small, tenting area, tenting height that's relatively short. These are all green. And then as you move across this table, multiple segments, Barlow's valves, small posterior leaflets, those are really red, and with patients that we wouldn't consider doing edge-to-edge repair. And then in the middle, we do make some judgment as to whether we think they're suitable for edge-to-edge repair or perhaps TMVR. So there's obviously lots of devices now for edge-to-edge repair. When that table came out, it was really just the NT device, but as MitraClip has added longer arms, they've added wider clips, they've added independent grasping, and then there's the Pascal device that has all of those features plus the spacer. And so from an edge-to-edge repair point of view, there's lots of options. And here's a table that we put in that paper that really hints at what we think are the right choices when we come to edge-to-edge repair versus TMVR. So for edge-to-edge repair, if there's a contraindication to anticoagulation, they should get edge-to-edge. If the MR is central, probably edge-to-edge. If their mitral valve area is good, if there's no stenosis, no calcium, long leaflets, all the things that I hinted to in that other table, they should probably get edge-to-edge repair. Interestingly, down at the bottom there, we said that if they have concomitant significant TR, and that's amenable to plication, then maybe they should have edge-to-edge repair, because maybe you should do both valves at the same time. Whereas for TMVR, if it's commissural, if they have a broad jet, if they have a small valve, if they have mixed valve disease with stenosis or lots of calcification, maybe we need to think about TMVR. Same thing with short leaflets. Same thing with the Barlow's valve or a cleft. And so when we think about TMVR, as Philip has highlighted over here on the right, Lvo2 obstruction is a big deal. So if there's a high risk of Lvo2 obstruction, obviously you can't do it. And just the other thing, the obvious things to point out is that it's a dynamic valve, it's asymmetric, it has a saddle state annulus, it has complex subvalvular apparatus. And so all of these place challenges for the delivery, position, anchoring, and sealing of TMVR. And we'll see that the devices will likely change over time. And so this is a relatively a nice representation of the devices that are available. The big ones being Tendyne, and for us, SM3 and the Evoke. And then the other devices are all out there. So I have 3 cases to show. This is the first one with severe mitral regurgitation, functional, ischemic cardiomyopathy, NYHA class 3. And I really want to just highlight some of the anatomy that would suggest this patient is not a good candidate for edge-to-edge repair. And so you can see this area of dropout and restriction with a very short posterior leaflet and significant calcification. So we said this patient should not have edge-to-edge repair. And we actually went ahead and we put an SM3 device. And so I'm not sure if you're familiar with the SM3 device. It has a dock, it has a Sapien 3, a 29 Sapien 3 valve that has a covering on the outside. And so the dock is placed in the ventricle around the chordal structure and the leaflets. And then there's an atrial portion of the dock. And then inside that, you place the SM3 device. First 10 patients we published, technical success in 9, no mortalities, no strokes, in the hospital for a day and a half with a significant improvement in functional class. Here's a patient from a couple of weeks ago, very significant calcification. And here you'll see, similar to that patient, a lot of MAC and a very short leaflet. And so what's the right option for this patient? Given the significant amount of calcification, SM3 is probably not the right option, but maybe Tendyne is the right option because it seems to deal with the calcification better. And this is the 2-year data from the 100-patient series showing a significant reduction in mitral regurgitation that's sustained out to 2 years with a significant improvement in functional class. And so finally, the Evoke system. So this has a unique anchoring system where these tabs come out by twisting the knobs and you interact with the cords and the leaflets. And it has an interannular sealing skirt that minimizes paravalvular leak, a very sophisticated steering system that allows you to become coaxial with a valve from a transeptal system. It looks similar to MitraClip, and it has 2 valve sizes. And so here's a patient that we chose an Evoke device because of a very broad jet with lots of leaflet length and a low risk of Lvo2 obstruction. And so I think you can see here that probably that edge-to-edge repair is going to be difficult in this patient, especially to get a significant reduction in MR. And so I don't show you the procedural video, but here's what the Evoke device looks at immediately post-procedure, had a good outcome. And so here's a final case. And this was a case from last week, 67-year-old, severe functional mitral regurgitation, ischemic cardiomyopathy on good therapy. And I think many centers would try edge-to-edge repair here, but there's multiple jets. It comes all the way across the coaptation surface. And I think that really in this kind of patient, we need to think about a different option. And as Philip has said, we need to incorporate CT because we really need to consider the neo-LVOT. And so for this patient, there's a very large neo-LVOT, and we suspect this patient will get included in the TRISCEND SM3 trial. So I think I'm over by a minute, but those again are my takeaway points. And I think that the big key about all of this is excellent TEE in the screening phase, excellent CT, and then a choice of what devices are available. And that's it for my talk.
Thanks. Thanks, Dr. Bohm. Excellent talk, as usual.
Very short.
Very balanced talk about the clip device and the TMVR. I think I really like it. Good talk because so very balanced. I think for this kind of device, it's a clip is a very good technology. It's very simple and low risk. I just wondering. I think you have quite experience for the emergency clip for the unstable patient. What are you any comments on this kind of?
That's a good topic. So I think more and more we are using the clip in patients that are presenting with cardiogenic shock and severe functional mitral regurgitation. We've done a few patients that are on inotropes, and they seem to have a substantial benefit. We haven't done any acute papillary muscle rupture patients. There is a series, international series would be presented, and it seems to be a very, very good option. Even if you can delay surgery 2 or 3 weeks in patients that have an acute papillary muscle rupture, that seems to be a huge advantage to patients. So I think definitely it's a technology that can be used if you're familiar with the device in a very sick patient, even to temporize. So that's a good discussion. Thanks, Shan.
Oh, as like a bridging this kind of situation.
Yeah.
So we have a few more minutes. Any comments from panelists?
Okay, I have one question to Philip and Robert, and you are very expert in the TMVR and the TIR procedure. So I have one question. Usually in patient with hypertrophic cardiomyopathy, usually at the resting phase and the Lvo2 obstruction, it doesn't matter. But Philip, you shows according to the cardiac patient, there is some flow dependent, neo Lvo2, some difference. So my question is about you shows a very diverse anatomy case of Lvo2 after implantation of the TMVR, but is there any functional concept of the flow dependent or any some, the resting phase is okay, the patient is during the exercise, that would be some problematic. How do you think about the neo Lvo2 concept with some functional, concept?
So I think that's a very good point. So when we started off doing those simulations here in 2014, we would do them at end systole and end diastole. We just kept it simple. Others started doing that multi-phase. And that brings in the point to actually look, what is happening. You could actually also just average both. You could be more granular and see what is the change in LV volume between each phase and figure out, how much is the ventricle ejecting. That's all nice to have. And perhaps in the future, and in 5 years from now, we will have software doing that automatically, because up to now, that's actually too much work. And you wouldn't actually do that in every case, only in borderline cases. But then all those granular assessments, they still fall short of what you're saying. We don't know what happens. We actually only know what is happening in terms of cardiac function at the time point when the CT was obtained. We don't know what is happening if the patient is challenged with volume or is running dry versus is exercising or not, and how the ventricle is remodeling. Those are all unknowns. Yeah, and that's of course somewhat unfortunate. I don't think there's any feasible approach to actually solve those questions. It may just be that we're actually creating too much headache about that. Yeah. Also, what one has to understand is, apart from the neo LVT for valve and valve implantations, when you're looking at those dedicated TMVR devices, whether it's Intrepid or Tendyne. Intrepid, it's in the publication which I featured. Tendyne, we had a presentation at EuroPCR. The neo LVT is always larger, or most often larger, after the procedure than simulated, because we actually simulate the worst case scenario with the most proper seating. With Tendyne, often you end up sitting a little bit higher atrial. And that may actually then also allow for more space in the neo LVT.
Great. Well, I agree with Philip.
Good point.
Yeah, I agree with Philip that I think that the reality is that those patients that are TMVR candidates, so they can't be treated with edge-to-edge repair, they're not surgical, that have significant asymmetric septal hypertrophy are very rare. And I think that what we would do and what we have done with these patients, it's highlighted at the time of the case discussion rounds. And we go back to the angiogram and we see whether they have a large first septal perforator. And if we think that they're borderline, but they have a large first septal perforator, I think we would go ahead with a valve implant if we think it looks okay. And with the idea that if there's a problem, we would ablate it, alcohol ablation. We have done 2 patients where we did alcohol ablation first and then looked at the neo-LVT and then decided whether we were going to do an implant. For edge-to-edge repair, it's not an issue. And some people are advocating for edge-to-edge repair, and those that have significant SAM, we haven't done any, but other centers have for sure.
Any other comments?
I know ask Dr. Boone about the failed mitral valve after mitral valve repair with the ring annuloplasty. I have some patients with a previous ring and new coda formation patient, and after the surgery, after some years, the mitral valve failed with the mitral valve prolapse. And in those cases, do you consider TEER or TMVR?
So I think TEER is a very safe option, and I think a really good option. So again, anatomically, it needs to be really looked at. And if you think you can get a good grasp with a good bite of tissue, I think TEER is the best option. If it's not for TEER, then it becomes a little complicated. I think the SM3 device is a very good option for that kind of patient because you can go and gather up the leaflets. The difficulty is that you tend to enter on the medial commissure and then push the first turn anteriorly. Now, if you've removed the medial commissure with your annuloplasty device, it becomes quite difficult. And then there's the option of a valve and ring with some kind of procedure to slice the anterior leaflet to get it out of the way. We haven't done any. We haven't pursued that. There's definitely centers that are doing it. I haven't been overly keen because I think it's a challenging procedure to get a good result.
I think we can have one more question. We have 1 more minute.
We can ask Robert Boone. So if in future as the technology for mitral valve replacement or transcatheter mitral valve replacement matures, will it become the default option? And then that means that the edge-to-edge repair will be, distant second choice and maybe obsolete one day.
Yeah, so I think that's a really good question. I think that nobody knows. I think that for people that do TAVI, they like the idea of a quick, straightforward procedure where it's reproducible and the MR reduction is excellent. I think like surgery, any patient that can have a repair is probably better off to get a repair. And so for patients that are in that green category for TEER, I think they should have TEER. It's just my bias. But for patients that are orange or red, they should get a valve replacement. Jan's, you're a mitral surgeon, Jan. I think we all feel the same way that repair is better than replacement. The downside of TEER is that once the clips are there, you basically remove other transcatheter options. And so that's the balance, is that if you're removing transcatheter, if you're doing a TEER procedure, you're removing transcatheter options in the future. And I think that's going to be the difficulty.
I agree. There's so many different technologies. I think that we just need to carefully, think about which one is the best for the patient in the future, like a second intervention. I think that's also important, particularly if you move to the young patient, and we more think about as a subsequent like intervention, what possibility after the first one. So I think that's very important. So if there's any major question or burning question, or I think we are probably now it's almost 1.5 hours. I think I will close this session. And thank you very much for the live case operator and lecture by Dr. Boone and Dr. Blank. Thank you very much for the excellent talk. And thanks to all the panelists for the great discussion and excellent session. Thanks again.
Thank you, everybody. Thanks very much.
Thank you, everybody.
Thank you.